Okay, welcome everybody. We will get started since we have a full hour here. Thank you all for joining. I'm April Harrington, the project manager of the Chicagoland Healthcare Workforce Collaborative, and I am so excited to be here after over a year of researching how frontline healthcare workers perceive their opportunities to advance in the field. We finally have our findings and our report. So pleased to have Ellen Frank Miller here, the founder and CEO of the Workforce and Organizational Research Center, to walk us through those findings. In case you haven't had a chance to see the full report, I will drop that in the chat right now. It is on our website in the resources section. Also attached to the event post for today's event. So feel free to dive into it after today. Ellen will walk us through the high level findings. Today's event is recorded, so the recording will also be available on our website as well as the slides and the full report. And I'll also send them out in a newsletter. Next slide, please, Ellen. So here's our agenda for the day. First, I'll talk a little bit about why we pursued this research. Then I will pass it over to Ellen to talk about the research design and to spend some time on our aggregated survey results. And then Ellen will pass it back to me to talk about some of the possible strategies that we have identified to pursue based on those findings. And we'll also have a little employer spotlight from one of the employers who took part in this research project, University of Illinois Health, who will give us a sense of what they plan to do with this research and what they are already doing internally that aligns with some of those possible strategies. Next slide, please. I think most of everyone on this call, I'm seeing so many familiar names, are fully aware of who CHWC is. But we are a employer-led sector partnership made up of nearly 12 of Chicago's major health and hospital systems. We are here to come together with our industry partners to support a more inclusive healthcare workforce and provide accessibility to underemployed populations, while also addressing the ever-evolving and growing need for talent in this sector. We focus on local and targeted hiring, on partnering with our education and training providers, and on retention and career pathways, which is really what led us to this research to begin with. Is we don't want to just bring people into frontline positions and leave them there. We want people to be able to advance into family sustaining and wealth building careers in healthcare. Next slide. So how did we get here? Why did we choose to do this research? I came onto the Chicagoland Healthcare Workforce Collaborative in late 2020, about 6 months into the onset of the COVID pandemic. CHWC had been around since 2016, but not unsurprisingly, COVID changed everything. A lot of the committees and work that we were pursuing in the table were sidelined for a while. And the previous project manager had left, and there was a little gap before I came on. So in early 2021, I hosted a series of meetings and discussions to reflect on the history of CHWC and the importance of this table, and to talk about what strategies we should pursue moving forward. You'll all remember that early 2021 was a pivotal time in the COVID pandemic. It had been around for a while, but had no end in sight. And it was really weighing on our healthcare professionals in particular. This is also the time when the Great Resignation started, and we saw people leaving their jobs in many different sectors, healthcare included. So this is the context in which we were having these conversations. And something that kept rising to the fore was our employers saying, we recognize that we need to do more to help people advance. Our frontline employees are interested in it. They're asking for it. It's not only something that's necessary for retention, but it's necessary for attracting new talent. new talent coming in the door wants to know what their opportunities to advance will be. And there was a recognition on a part of our employer partners that we can't just leave this up to employees and training providers anymore. We need to be more intentional. We need to have more skin in the game and build more strategies internally to help people advance. But how do we do that? That's what our employers were wondering. What support do employees need in order to advance, and how can we provide that? So that's how we conceptualized this research project and found Ellen and the Workforce and Organizational Research Center. One of our ultimate visions for this, we're not quite there yet, but we have made some great strides, and this is still a part of our future vision, is to create employee and job seeker facing resources, career pathway maps, so to speak, or career advancement navigation tools, so that people in these frontline positions can have a better understanding of the widely varied opportunities to advance in healthcare. We all know that there are just a bajillion different specialties and job titles and certifications and training programs that go along with those specialties. So this is something that we're still trying to do. This research helps us get there, and I'll talk about that a little bit later in the hour. And then I believe now I'm forgetting if I have another slide. Without further ado, I'd like to introduce Ellen Frank Miller. I just want to take a moment to personally thank Ellen and her team. They have been, an absolute joy to work with. They are not only excellent researchers, but they're creative and flexible and patient, and they've just been wonderful to work with. So Ellen Frank Miller, the founder and CEO of the Workforce and Organizational Research Center. I'll pass it over to you.
Thank you so much. And I'm going to take a moment to turn the compliment around both to April, who has been intrepid in this entire effort, and also to the participating healthcare systems who have worked incredibly hard to make this research possible, and have also been flexible and creative and very patient. So quick background on me. So I started my career in human resource consulting for 15 years, and there were problems we could not solve for clients regarding their frontline workforce because there was just a lack of research evidence that we could use as a basis for solving problems. So I eventually left consulting. I went to UChicago to earn my PhD, and then was at Washington University in St. Louis conducting research on this topic. And in 2021, I had the opportunity to put those two pieces together and to continue to do research in partnership with nonprofits like the Funder Alliance and the CHWC, and then also to, in certain cases, work on the ground with employers. So this was a really exciting project and opportunity for us. And the way that we approached this was really looking at, if we want to understand employees' perceptions of their career pathway opportunities, the first thing we need to do is understand the perspective of the employers. What are employers currently doing? What are they striving towards? Where do they think they are today? Where do they think they need to improve? And getting that employer perspective first task. So this is why we used mixed methods. So we started with a qualitative investigation. The five hospital systems that were participating, they provided some administrative data about the number of jobs that they had that fit the categories, and I'll go into that in a moment. What were wages, what were turnover rates, et cetera. And then we did interviews as well, and that gave us sort of the perspective on where's an employee coming from. So the employer coming from. So we did leadership interviews with senior folks, with HR leaders. We talked to some frontline supervisors as well, and then that gave us the information we needed to know what to ask employees about their perceptions, and that allowed us to do a survey. So you can see here there were 5 healthcare systems that made an enormous effort to participate, and as April said, we started this in January prior year. So as I was saying, the point of understanding the employer perspective was to get the lay of the land and know the right questions to ask employees. As I said, we had 9 interviews with leaders from 5 systems, and then 12 interviews with frontline supervisors from 3 of the systems. And using that information and perspective, we designed the employee survey instrument. There were 4 healthcare systems that fielded it. What I'm going to show you are aggregated data. So no individual healthcare system is identifiable in this. We just stripped all the identifying information, mushed it all together into a single data set, and then learned from that. And the group originally thought really carefully about what types of jobs from the frontline were the ones that were most important to try to find ways to advance and to understand the needs for their career pathways. So these 3 positions, certified nursing assistants, and they have different names at different healthcare systems, but certified nursing assistants, medical assistants, and also patient service representatives. These are all entry-level jobs. Now, 2 of them are clinical, obviously, but one of them is an entry way for folks who may not have clinical certifications or may not be interested in clinical work, but are interested in careers in healthcare. So that's why we focused on these jobs, and the surveys were sent to folks just in these roles. So the results you see are just from frontline healthcare workers. We fielded the survey in February, and it was kind of staggered between the systems, but closed everything in June. There were a total of about 7,500 employees across those 3 job types that received the survey. And overall, the response rate was low. We had an overall response rate of 7.6%. Now, this was not unexpected given all the incredible pressures that are going on within the healthcare sector, both at the level of all of you folks who are here and also in terms of those frontline workers. So recognizing, and here you can see we had somewhat better response rates from the patient service representatives, the PSRs, and from medical assistants, the MAs, than we did from the CNAs. But overall, we had almost 600 total responses, which from perspective of math gives us a nice opportunity to have some confidence that what we've found, we can feel good about how we analyze it. When you look at a really small sample of like 50, you get a little nervous that, well, do we have enough here to work with? So we felt good about the total we had. And the way we looked at this was, while we know we can't represent the opinions of all the CNAs and MAs and PSRs across these systems because it was a low response rate, what we're able to surmise is that when people get a survey about something, if they care enough about it, they may respond to it. If they don't care, they may find it interesting but not bother, right? So the mating habits of hippopotamus are really interesting, and I am not going to take my time to respond to that survey. But if someone asked me about lower wage work in the healthcare system, I'm interested in what they want to know. So we looked at this as the group that responded here are the most invested stakeholders. They are the frontline workers who cared enough about career pathways in healthcare to actually complete this survey. So we kind of think about them as power users. And if we meet the needs of the folks who are most interested in advancing in their healthcare career, we know that that will benefit all the others who maybe didn't respond, maybe people who just haven't thought enough about what they want to do with their career, or folks who are, well, this is a job for me, but learning more about opportunities might encourage them to think about a longer career path. So that's the caveat about who we're talking about. And I'll repeat that as we go through, because it's important to remember that we're reflecting the perspective of people who really care about their pathways in healthcare. So there were 4 major themes overall that emerged. The first one was that the folks who responded to the survey were generally happy in their jobs at their healthcare systems. And while they did feel like they had opportunities to gain skills, in particular on the job, cost was a barrier to gaining skills that would require additional outside training for them. There was interest in advancing careers. So anytime you might sort of hear like, well, people are kind of complacent in their jobs. And, if that narrative is going around, at least for this group of folks, they're really motivated and they do want to advance. They're not sure that they can. But the interest is there. And that was really important, because if you find out that people are like, nah, not thinking about my long-term future here, then you have to say, well, should we invest in making career pathways? But the answer here is that people are interested, and they really would like more guidance on how to advance their career. So that was an important finding as well. So let me get into some of the details of the different categories that we asked employees about. So with regard to job satisfaction, as I mentioned, people are pretty happy. The folks who responded to this survey, the ones who are real committed to career pathways in healthcare, they are not a high turnover risk. This particular group are engaged. They are not interested in leaving the field as a whole, and they really do, feel like this job works for them. So their work-life balance is good. They feel like they have pretty good support from their supervisors, support from their coworkers. Coworker support is often higher than supervisor support, and it's always nice to know that people like who they're working with, because that's an important factor in retention. And when asked about whether they got recognition for the work they did, they felt pretty good about that. So this is sort of the high level picture of where this particular group was with job satisfaction. And in a way, this is probably not totally surprising, right? Because these are the people who are committed to staying, and they wouldn't be committed if they really weren't happy. We asked about opportunities for skill building and any barriers that they experienced. And as I mentioned, skill building on the job, this was a really strong response. People really felt like in their day-to-day responsibilities, they were building skills. They also felt like, yes, there are opportunities for training outside of their healthcare system. So they're aware of, that there could be other certifications, or they could get an associate's or a bachelor's degree. And they're also aware that there are some education benefits offered by their employers that could help them with the cost of that. Now, one thing they weren't as sure about was internal training opportunities, but again, this is aggregated across 4 different healthcare systems. So there can be variation in both the availability of internal training opportunities and the knowledge of those opportunities. So this one was a little bit hard to interpret. But one thing that came across clearly is that they were concerned about the cost of obtaining additional education and training outside of what they could learn on the job. And April will talk about where some opportunity areas might be related to that. So the other question then was about opportunities for advancement. So skill building, and then also advancement. So they do have aspirations to go beyond where they are today. And they frequently said, this job is a stepping stone for me. So that's exciting, because when people start thinking in terms of stepping stones, they're thinking in terms of pathways. So when we wrote this particular survey question, we were really interested in whether people would respond to it's a stepping stone, and they did. So again, that's part of why we surmise that these are people who are very committed to advancing within healthcare as a profession. At the same time, they weren't sure about their ability to advance within the job they were in today. We asked about whether they felt like they would need to leave their current practice or department or the location they were in terms, inability, in order to advance. And they did feel like that was probably necessary. Although in terms of like, well, would I have to leave my healthcare system to advance? Not as strong of a feeling on that. One thing we asked, and this goes to some questions we often have about equity and inclusion, is whether people know of people like me who have advanced. And that can be an indicator of whether folks feel like maybe there's discrimination going on. Like, oh, sure, people advance, but not people like me. And in this case, they did, for the most part, there was a positive response that they did know people like them who had advanced. At the same time, they weren't sure if it was true that it was just based on anyone who works hard. Which is not an uncommon response, especially when you're looking at a limited group of people. But again, one thing that came up when we asked them about opportunities and barriers for advancement beyond skill building, education and training were seen as a barrier. So that suggests that I can't advance without this education and training. That is limiting me right now, and cost is a barrier to me actually getting that training that would allow me to advance. We also asked, as I mentioned, about career guidance and overall organizational trust. And there was a sense that there could be better career guidance opportunities. And they generally felt like their healthcare systems were keeping the promise that this is a good place to work, which is related to their job satisfaction results. But one of the questions we really like to end surveys with is, I am confident my organization will act on the results of this survey. And the reason we ask that is about whether people believe their employer cares about what they're saying. If a company or an organization is going to the trouble of getting voice, raising worker voice, and getting the input from their workers, it's really important that those workers then feel like, I've gone to some trouble here. Do you take me seriously? So this was a neutral response. It wasn't a negative, but people were sort of like, yeah, maybe. So this is a great opportunity area for folks to use the results here, and not just those who participated, but for others to say, hey, there was this study and this is what we learned, and here are actions we want to take as a result. So there's separate research that demonstrates that when organizations do this type of employee listening activity and they respond to it by communicating back to workers, and even if their response is, we heard you, we understand your priorities, we can't do that. But here's what we're going to try to do instead, and we're going to work towards this. Even when it's bad news, the fact that they were listened to seems to have a positive impact on things like turnover and tension, et cetera. So this is an opportunity area. What I want to show you right now, I will give you we'll walk through this carefully, so don't be overwhelmed here, but we did want to know if there was any variation in the perceptions of workers based on the type of job that they were in. So we had CNAs and MAs and patient service reps, and we asked questions that we knew some places we would expect some variation, but we wanted to lay it out here. So the green places, the places where you see a green number indicate that the employees in those jobs had more positive responses to these questions than employees in the other jobs. And the red is the opposite. So where you see red, and we're going to go through these individually, where you see red, it indicates that employees in those jobs had lower scores than folks in the other jobs. The little notation you see underneath, P less than 0.01, P less than 0.05, all that's telling us is that we can feel confident that this is not some random finding that's due to chance. We are highly, highly confident that this is really a difference between folks in each type of job. So let me go through them one at a time. So the question was, and this is agree, disagree scale, I have real opportunities to advance at my healthcare system. And you can see here that medical assistants with, so the neutral, the 3.0 is the middle of the scale. Medical assistants had a lower response to this question than CNAs and PSRs. So the way we interpret that is that PSRs and CNAs are more likely to feel they have real opportunities to advance here. And I want to stick with the medical assistants for a moment, because you'll notice in that column, there are 3 places where medical assistants scores were lower than the other job types. So first of all, medical assistants were less likely to say they had real opportunities to advance. They were also less likely to say, my supervisor would give me the flexibility if I needed it to get the training I would need to advance. And then they were also less likely to say, my supervisor talks to me about my career goals and how I can reach them. So it's informative that medical assistants in particular seem to have deficits in these areas. Now I want to contrast that with certified nursing assistants who, as you can see, they're all green. The differences mean that these CNAs, this job type, people had more positive responses to these questions. So the question is, I know what I need to do to advance at my healthcare system. And so the CNAs are much more confident. Yes, I know what I need to do. They also are more likely to say they see their current job as a stepping stone to the job they really want. They also more likely to say they feel like they're on the road to reaching their career goals. They feel like there's someone at my healthcare system who can guide me towards reaching my career goals. So they're more likely to indicate that they have some kind of career guidance available to them. So these things put together, suggest that there's a difference in these 2 clinical roles and how people feel about their opportunities to be supported in advancement. The PSRs are an interesting mix, and some of this makes sense when you think about it as not part of a clinical context, right? So PSRs were more likely to say that they can advance at their healthcare system without earning a new certification or degree, which makes sense. And they're less likely to say that they couldn't afford training they would need to reach career goals. So again, we look at that as this is an area where, although folks do need to build skills to advance, they may not feel that training is holding them back. And so that element we talked about in terms of the cost of training as a barrier may not apply as much to this non-clinical role. So with that, I will turn it over to April to talk about what the implications are for some possible strategies.
Thank you, Ellen. And I do encourage anyone to put questions in the chat. We will leave some time at the end of the hour for questions and just general discussion. But feel free, drop them in. So these are the possible strategies to address some of the findings that Ellen and her team worked on, and I gave some input as well. First, as Ellen pointed out, the cost of training and education is a barrier for frontline workers in healthcare to advance. So one of the opportunities is to redesign employer tuition supports. And I'm happy to hear that this has been a topic of conversation that I've heard over the past couple of years at this table. We've heard it time and time again that not everyone can access tuition reimbursement because they can't pay for it upfront. I actually recently met with Guild, which is a company that acts as an intermediary between employers and the training institutions and the employees to facilitate tuition supports. And they went through some research with me, which I was trying to pull up before this call, but I couldn't quite find it. But they showed that, research states that even if tuition reimbursement benefits include associate's degrees, short-term certificates, even GEDs or English language learning, that utilization rates of those programs are very low. And those who are utilizing tuition reimbursement are mostly pursuing master's degrees or bachelor's degrees. And that signifies that those are professionals at a stage in their career where they have more expendable income and can afford that tuition up front. I'm happy to report that I'm already seeing movement here. I think Northwestern has just made a change where several of their programs, or they will support several training programs up front as opposed to reimbursement. And Advocate Aurora has announced or will be announcing soon that they are going to anyone who makes $55,000 or less as a yearly salary will be able to access tuition coverage upfront as opposed to reimbursement. So this is really a positive change. I hope to continue to see that shift, not only in healthcare, but in other industries. The second here is to develop paid apprenticeship programs or earn and learn programs. And we are seeing some of that. Rush, for example, is launching a program to train existing nursing assistants to pursue their associate's degrees in nursing, and then from there to also pursue their bachelor's degrees. And that tuition coverage is completely covered up front. That's a partnership with Malcolm X. It's actually a program that is being funded through the Good Jobs Challenge through CHWC. And I know that other systems are also working on building programs to train incumbent workers in these frontline roles and to give them the opportunities to advance, which is fantastic. What I haven't heard as much about is those systems actually paying for the time that those employees are going to spend in school. So we're still, leaving folks out who can't afford to cut down on their hours. And as we know, CNAs, PSRs, MAs, they don't make a ton. They don't, this isn't a high wage job where we can expect that people have a lot of expendable income to take time off. So that's another opportunity. keep those questions going, and I'll turn it back to Ellen to address some of those in a moment. But Ellen, can you switch to the next slide? Another thing we found is there's, a lack of awareness of internal training opportunities. Some of that is because there might not be enough internal training opportunities, or the eligibility might be somewhat restricted. So, as these new tuition support programs are rolling out and folks can access tuition support up front instead of reimbursement, that'll only be effective if we make sure people know about it, right? I also know about a couple other programs I want to elevate. Advocate Aurora has a Navigate program that combines career coaching and mentoring and training to help frontline workers advance. And they've seen some great success with that program. Advocate, in partnership with University of Chicago Medicine and Sinai, built a 3-prong workforce development program several years ago, and that featured 2 different programs to increase skills of existing workers. One to bring people from the front line into that next career ladder. Another one more focused on leadership. But I want to point out that often those programs are grant funded. These are often grant funded pilots that may reach a relatively small percentage of the entire workforce in these large systems, and then grants run out. So it's a problem for us all to address together, is how do we transform these pilot programs into more sustainable solutions and more sustainable practices. Next slide, Ellen. And I'll address that in a moment. And then one of the other things we saw is a lack of career guidance. So one of the things that came out of this research is that not that many employees are saying that my frontline supervisor talks to me about my opportunities to advance. I know that can be a challenge because frontline supervisors don't want to lose their talent, and they don't want to have people move outside of their department, their unit, their location, and then to have that job go unfilled for a while. But here's, perhaps an opportunity for some systems change here is how do we equip supervisors with those skills to mentor their frontline employees, and how do we build the value proposition to them to encourage them to have their frontline workers advance. And then, of course, posting promotion opportunities internally is always a strategy. Next slide, Ellen. I want to, for anyone who isn't aware, I want to tell you a little bit about one way in which we are going to use this research within CHWC. So CHWC is part of a larger group of organizations in Chicago that have been awarded the Good Jobs Challenge grant from the Economic Development Administration. And we have chosen to use our funding in part to transform how we are training CNAs, and to really hold true to that promise that becoming a CNA is a foot in the door and the first step towards a long-term career in healthcare that leads to wealth-building wages. So we are bringing together distinct CNA training programs that have existed at our employer systems and exist to bring people into that job as a pipeline. We're asking all those programs to come together, share what's working, solve challenges together, and co-design program interventions that help strengthen job quality for CNAs, and in particular, strengthen career pathways. One of the things we're doing here is building a career pathway exploration tool that lists, exposes a CNA to all the different opportunities to advance, whether that's in a traditional nursing path or more of a diagnostic path into one of the many tech roles that are out there, EKG tech, MRI tech, sleep tech, or a more administrative role or public health role. So we're trying to put together a tool that outlines all of these different occupations that you can get to with an associate's degree or less, or just an additional certification, and display that information alongside salaries, expected salaries in Chicago, and the training programs that are available in Chicagoland with the length of time it would take to get through those. And within this program model, we actually want to support people going through those programs. So I just wanted to elevate that. If anybody doesn't know about it, wants to learn more, let me know. And then the last slide, Ellen, on my part. And so I know one of the reasons we pursued this study was to find out, where are there opportunities to increase, to use some philanthropy to support some systems change and support the goals of this study, which is career advancement for frontline workers. One of those opportunities is to help support this certified nursing assistant pipeline and pathway program. A lot of those dollars from the Good Jobs Challenge are going towards training, but there are other pieces of this model, this project idea that could use some additional investment, like the development of the shared career navigation tool, designing and implementing additional program interventions. One that we haven't discussed in that community of practice, but which to me is an idea that comes out of reading this study, is supervisor training. How could we equip supervisors to better talk to their frontline workers about advancement? And of course, additional programs, participants, and tracks. The Good Jobs Challenge funding goes through the end of 2025, which feels far away, but it will be here before we know it. And it's always a shame to put so much time and energy into these programs and to have the grant funding dry up and to not be able to pursue them anymore. And with that, I do also want to elevate that all of these CHWC employer partners have programs, have program ideas that touch on these ideas, the need to advance frontline workers, and they need funding for them. So if there are any funders on the call who want to know who those programs are or where they are, feel free to reach out to me. Before I hand it off to our friends over at University of Illinois Health, I wonder if I've seen lots of questions in the chat. Ellen, maybe we can tackle some of those before handing it off to UI Health, and they can tell us how they're going to use this study. Eileen asked, curious if the MA role has less movement and growth than a CNA due to the nature of the role and the interest of the person in the role. CNA seeing more movement due to the nature that they are often training RNs in the CNA role. I'm not quite following it completely, Eileen, but
April, I think Ellen answered it, but essentially my queerest question was basically, are MAs more likely to be staying in the role? Is that how they're viewed over the long term of retention versus a CNA? There's a tremendous amount of movement. Often nurses are in training and they'll work in a CNA role. So, but Ellen answered it. She said they didn't ask the questions, so it's not necessarily clear. I think I know the answer to it based on hiring, but at the same time, I was just curious if it was a question asked, and it wasn't, but that's okay. Thank you.
Of course. Got it. And Laura also.
April, I apologize. I may have jumped the gun by answering questions in the chat.
No, I'm glad you did. I just saw it all, so I wanted to make sure we weren't leaving that. But Laura, also to that point, Eileen, and Laura's comment of like, is there a next role for an MA? What would it be? What is the strongest pathway? This is something that, we had some learning events at CHWC about MAs a couple of years ago. And, it's one of the reasons that I, didn't push for us to pursue training MAs under Good Jobs Challenge funding, is it pays, a little bit more than CNAs according to our data, but it takes so much longer to get into that role. My understanding from MA training is there are lots of different skills that MAs need to learn in order to become certified, but they're not always using all of those skills. I've heard that the job of an MA can look very, very different depending on where you work. And I think that is it's an excellent question, Laura, and one that I haven't been able to find the answer to. And it seems that perhaps MAs are also asking that question. Alicia, I believe there are definitely some unionized environments here. University of Chicago Medicine's CNA staff is unionized. I can't think of the others offhand. And we do have some of the participating employers on the call, so I encourage you to also respond to this. Let me pass it off to Odana Sandoval and Kinga Keelman. Ellen, if you don't mind putting the slides back up, to talk a little bit about University of Illinois Health and how they're using this study. I'm going to try and comb through some of these questions too, and then we'll have time to just, everyone, come off mute and have a discussion. So Odanis and Kinga, thanks for joining us and sharing a little bit about your experience with this research.
Hi everyone. I guess we can make it short since I know you guys got a lot of questions and I'd be really interested to an open discussion. Some highlights from our end. We're seeing a lot of employees from all around the hospital system come over to our end in terms of workforce development, looking for career exposure and training. While our workforce development program is a little bit newer, on the newer side, we've been able to connect a lot of dots and provide a lot of resources for our employees and our volunteers to be able to help them upskill them, help them find a desirable training program, or help them build those skills that might not be so common. Whether somebody wants to go into a clinical training program or administrative role, we're there to kind of put those pieces together for them. And I know we talked about kind of incentives from the organizational point of view. On our end, UI Health offers a lot of state or tuition waivers for employees that attend state universities or state colleges. That I think that's a big benefit for our employees, and bringing our constituents into UI Health is the biggest pool that we have, and then we can offer them all these benefits as well. Kinga, do you want to go over the next two?
Yes. So I want to add one more thing to that you just, Danny, mentioned. So when they become volunteers, for example, even employees, they can become volunteers. And we also offer the CNA training, the MA training, the phlebotomy training for our volunteers free of charge. If they have that, for example, in their position, then, once they are employees, they can upscale to to a nursing school and continue their career free of charge. So they can do work and study at the same time. And we are trying to be accommodating with hours and whatnot. We are actually coming back from Malcolm X when we were with Danny this morning when we were doing outreach. So we are definitely partnering with the nearby colleges and other institutions as well. We're trying to build free upskilling programs, like I mentioned, the CNAs, MAs, and phlebotomy. We are actually working right now on the surgical tech program. However, it's a little bit more lengthy. But the pay is, you can make up to $80,000. So I think it's worth the hustle. It's only 18 months program, and even if you're making $40,000 or $50,000, that can double your salary. So I think it's definitely something that we'll be reaching out to our employees to go through the program, and we have the funds to actually for the employees to go through that program free of charge. Anything else that I'm missing? So the same thing with Malcolm X. They are very accommodating to the students as well as the other institutions that we are working with. So they understand that everybody has a busy schedules and a lot of things going on. So they're very understanding and accommodating. So that's really, we're very grateful for that. I don't know if
Thanks
anyone
for that,
has any
Kinga.
questions.
There are a couple questions about UI Health. Is UI Health unionized? Like, are your
Yes.
CNAs unionized? I thought so.
Mhm.
And are you a magnet organization?
I'm not sure what that means.
We work with union, yes.
And magnet is a nursing designation. I imagine you might be. Others know it better than I do, but with having a certain percentage of your nursing staff be a BSN as opposed to ADN. Am I getting that right to others on the call? I'm not sure. Well, thank you so much for sharing. I'm excited about some of the programs that you're thinking about building to upskill incumbent CNAs. I know that Kinga O'Donis and I have talked about that for something that's funded out of our Good Jobs Challenge CNA Pipeline and Pathway Hub. We only have 10 minutes left. Ellen, do you want to go to the last slide, which is just a couple discussion prompts, although I don't know that we'll need any help having a discussion. What's resonating with you? What policy or practice changes do you hope to see as a result of this research? Or what do we still need to understand better? Maybe let's just take the slides down and so we can all see each other. If you asked a question in the chat and no one answered it, feel free to just come off mute and ask. All questions, all comments are welcome.
I'll jump in. I just think, yeah, your report just like affirms everything I thought I knew. So at least I'm not dumber than I thought. So, thanks for the research to back it up. I think it seems to me in my anecdotal research over the last few years that the CNA is a strong pathway that, if supported well, could really convert to nursing. And there's educational pathways for that. It's clear. It's just a matter of like all these great strategies for how you make that easier. And the strategies you recommend, like, let's get those going. Cause that's, like I said, that is what I've heard for the last few years. I love the idea of an admin role in hospitals. That seems easily promotable to me. Admin skills are very skill-based and folks should be able to climb all the way up to big salaries that way. I think I'm curious about a lab tech role. The idea, somebody mentioned phlebotomy and how a phlebotomist might move in a lab tech role that could potentially elevate wages. I haven't seen that, but I would love to see an example of a system that's doing that. And nobody has ever been able to help me see a pathway from MA that's valuable. If I had the opportunity, I would tell everybody, don't be an MA ever. Don't be an MA. There's no value. Like, it's so, and the fact that again, you're seeing this role be so problematic. And yet at the same time, as a person who knows I will need a hospital system for my own health, MAs are invaluable in making it all work. So how do we solve this? Because that MA role is critical, but it needs a next step. So that's my soapbox. Thank you for this research to back up my soapbox.
I really appreciate that, Laura, because it was a little bit confusing as we were talking to a range of people, just out in the ecosystem to understand, an MA requires an associate's degree. There's a lot of overlap in what you're learning. And yet it didn't seem like you could apply that in the way that you can apply your CNA experience to becoming an RN. So thank you for that clarification. Still learning about this field for sure.
I wonder if anyone has some thoughts on that.
Rhonda, I saw your comment. Can you elaborate? Yeah.
Yeah, so I work for Loyola Medicine, and to me, for us, we have medical assistants only in our outpatient clinics. Well, you have a lot of nurses that go to people that go to nursing school because they want that bedside nursing experience. Well, where are we leading the people that want to go to the outpatient clinics? And outpatient clinics are like the new thing. So we need more medical assistants to pursue nursing to become our new outpatient nurses. They're in that setting, they're with them, they're with the physicians on a regular basis. Like, to me, that's their next move. They should be encouraged to become nurses as well and to focus on the outpatient experience that they're currently providing, but to continue to give that on a higher scale.
But let me just ask this quick question on that. Like, with a CNA, you're establishing credits that are valuable to a nursing degree. So when you get your CNA, you have credits that will transfer. So you're on your way. My understanding, and I could be wrong, is that that's the problem with the MA, is that certification, that MA education doesn't transfer. So you're asking people to spend a lot of time and money taking useless classes.
Well, not necessarily. So for, let's say someone that goes from high school straight to college, then they know they desire to be a nurse. Okay. So during that time, you even as a ADN, they're still going to school to be a nurse. You don't have to go to a junior college to be so they could be a medical assistant, right? So that's just a certification, just like CNA is a certification. You don't have to want to pursue nursing, but you can still be a medical assistant and go to my recommendation all times to a junior college to become a ADN first, just because they can get their foot in the door there quickly. I don't see there being like, oh, wasted classes, because you don't have to be a CNA to be a nurse. Like that's not a requirement. And for someone that is a medical assistant and they know they want to be on the outpatient side, that is the perfect pathway, because they are going to stay in that clinic environment. They're not going to go to bedside care where a CNA is doing bedside care. They're doing bedside care because they want to be inpatient nurses.
I think, sorry if what I'm saying is kind of irrelevant to the conversation going on, but I guess my understanding would be that, CNA, regardless of whether any of the actual classes or certifications do stack up, if you want to become a CNA and you want to become a nurse, it's a much shorter program. So even if some of those coursework, required classes to become, say, an LPN or an ADN, are duplicative, it's kind of 8 to 16 weeks of coursework to become a CNA. And so, taking that next step and getting your additional education, even if it is duplicative, would not be as much of an expense or time, constraint versus the MAs who have classes who are not, they don't carry over. You committed to 1 to 2 years of education and now have to start from scratch to get to what feels like a similar level. So it's almost as if those 2 years that you spent getting that MA, yes, you got the outpatient clinic experience, but to get to that next level, to become a nurse, it's almost like you have to start all over again. And I think that's what the difficulty is for a lot of people moving up. So again, regardless of whether it's duplicative or not, the classes, whether or not they actually stack up and get you where you want to go, it's less of a sunk cost with CNAs because that initial investment is a lot shorter in terms of education.
I also like to mention, I think there is value in the MA position. I think there's limitations to upward mobility, but in terms of providing that type of experience, whether it be in the outpatient care setting or inpatient, for folks that are trying to go into nursing or maybe a tech role or radiology or whatever the case may be, I think it still provides an experience for them. Whether they're studying to be nurses or they're going up further, it's still getting them exposure. It's still putting them in a patient-facing role where they're still able to do minimal procedures, unlike a CNA or let's say like a patient transporter.
I'm really interested in trying to get different healthcare systems and leaders to think about what supervisory and management experiences could exist that don't currently exist for MAs. You know, so many, at least at UCM, so many of our medical assistants are critical not only to that patient aspect, but also the fact that our clinics are able to run smoothly. And that requires, on top of that clinical know-how, you know, time management, being able to kind of make decisions on the fly, making sure things run smoothly. And I know that we really struggle with recruiting nurses to be able to manage and oversee outpatient clinics, since I think there is that desire to be bedside. And I'm wondering if there's an opportunity for us to think about, you know, what would it look like for an MA to become maybe a practice manager at outpatient clinics, and what needs to happen for folks to be able to do that successfully. I'm not sure if anybody, any systems here might have already thought of that, but it might be a conversation for another day.
No, I love that idea, Ashley. I think it's something we should talk about. I know we only have a couple minutes left. I want to thank Ellen Frank Miller and her team again at the Workforce and Organizational Research Center. They're phenomenal. This recording and slides and the report will all be on our website tomorrow. The report is already there, but I will add those to the website tomorrow. Anyone feel free to reach out to me to have some further conversations about what we can do with this research. And thank you all again. Have a great rest of your week.
Thank you, everybody.